All right, let's dive right in. Today, we're getting into one of the most fundamental and, frankly, fascinating puzzles in our field, the neurobiology of sleep. And as a psychiatry resident, you know this is about way more than just managing insomnia, right? This is about getting to the very core of psychiatric illness. So let's just start with this central paradox. Why is it that the exact same thing, losing sleep, can send someone with bipolar disorder into a full-blown manic episode, but for someone with depression, it might actually make them feel a little better, at least for a day? I mean, this question gets right to the heart of our clinical work. It shows us that sleep isn't just a passive symptom. It's an active player that can literally shift the entire course of a mood disorder. And if we want to treat these things effectively, we have to understand the why behind this. So here's our game plan. We're going to start with that big puzzle. Then we'll get under the hood and look at the brain's sleep engine. After that, we'll explore the two totally different worlds of sleep. Then we'll connect all that neurobiology back to the clinical syndromes we see every day. And finally, we'll wrap it up with a practical framework you can actually use on your next call shift. Okay, first up, sleep's central puzzle. The most important thing to get your head around is that sleep is not the brain just shutting off for the night. Far from it. It's an active, highly regulated brain state. And that means in our field, sleep disturbance is a kind of triple threat. It's a symptom of an illness, sure, but it's also a risk factor for developing one in the first place, and it's one of the biggest triggers for relapse. And look, we're not talking about some niche issue here, whether you're dealing with depression, bipolar disorder, anxiety, schizophrenia, or even neurocognitive disorders. Disrupted sleep is a core feature. It's pretty much the common thread that runs through almost everything we treat. So, how does this whole system actually work? Let's pop the hood and look at the brain's sleep engine. To really get why sleep goes off the rails, you first got to understand the basic models that keep it running. It all starts with what's called the two-process model. Think of it like this. Process S, the homeostatic drive, is basically a sleep pressure cooker. The longer you're awake, the more this pressure, this need for sleep, builds up. Simple enough. But then you have process C, the circadian drive. That's your internal 24-hour clock. It couldn't care less how long you've been awake. Its job is to tell your brain when it's time to feel sleepy. This model perfectly explains that classic patient complaint, right? Doc, I am bone tired, just exhausted, but my brain won't shut off. What they're saying is their process S is through the roof, but their process C, their internal clock, is totally out of whack. Now, building on that, we have the flip-flop switch model, and this is such a brilliant way to think about it. It explains how our brains make these incredibly fast, clean jumps between being wide awake and totally asleep. It's not a dimmer switch where you gradually fade out. Nope, it's a light switch. It's either on or it's off. And that's because the wake-promoting systems and the sleep-promoting systems are always actively trying to shut each other down. And here are the key players on the field. You've got your wake-up crew, the ARS, using all the neurotransmitters we know and love, norepinephrine, serotonin, histamine, dopamine. Then you have your sleep crew and the VLPO, which uses chill-out messengers like GABA. But here's the real MVP, the stabilizer, orexin. Its whole job is to hold that wake switch firmly in the on position. And this is why narcolepsy happens. You lose those orexin neurons, and suddenly that flip-flop switch becomes super unstable and wobbly. So once that switch finally flips over to sleep, what actually happens? Well, that brings us to the two different worlds of sleep. Because, not all sleep is created equal. We've got NREM and we've got REM. Probably the best way to think about this is that NREM sleep is the brain's housekeeper. It's there to do all the physical and mental tidying up, the restoration. REM sleep, on the other hand, that's the brain's emotional therapist. Its job is to process all the memories and feelings from the day. You absolutely need both, but they have very, very different jobs. So let's look at what the housekeeper is actually doing during that deep NREM sleep. You've got synaptic downscaling, which is basically pruning away weaker connections so you can learn better the next day. It's busy consolidating facts and memories, and it kicks on the glymphatic system, the brain's waste disposal service, to clear out all the junk that built up. This is why it's so clinically important when we see reduced slow-wave sleep in depression. We're literally watching a disruption of these essential restorative brain functions. And then you flip into REM sleep, and it's a wild scene. The brain is on fire, super active. That's where all the vivid dreaming comes from. But at the same time, the body is completely paralyzed. This state is called muscle atonia. The crucial job here is processing emotional memories.
And this explains that classic biological marker for depression, a shortened REM latency. It means our patients with depression are jumping into this intense emotional processing state way, way faster than they should be each night.
Okay, that's the science. Now, how does all of this actually show up in the clinic? This is where we connect the dots between circuits, syndromes, and the medications we use. This is where we see how these tiny system breakdowns create the illnesses we treat and how our drugs actually interact with them. Just look at these patterns. They tell a story. Depression isn't just "I slept poorly." It's a very specific signature. Less of that deep, restorative slow-wave sleep and that quick jump into REM. Bipolar mania, it's defined by a massive reduction in the actual need for sleep. And anxiety so often shows up as this choppy, fragmented sleep. See, these aren't random. They are the direct result of the underlying circuit problems we've been talking about. And this is where we come in. This is how our tools mess with those circuits. When you write a script for an SSRI, you're not just hoping to affect mood down the line, you are actively suppressing REM sleep from night one. When you use an antipsychotic for sedation, you're usually using its antihistamine properties to slam the brakes on that wake system. And when you give lithium, you're talking directly to that master circadian clock. We are, in a very real way, sleep architects. And this right here, this is a huge clinical pearl. You gotta remember this one. When your patient starts a new med and calls you a few days later saying their sleep has changed, for better or for worse, that is often the very first sign that the drug is having a real biological effect on their brain. It's an incredibly powerful early clue that you're on the right track. Okay, let's land the plane. We've covered a ton of ground. So in this last section, let's just boil it all down into 5 high-yield principles that you can take with you and actually use. So here they are, the big 5 takeaways. 1. Sleep is an active process, not a passive one. 2. Remember the flip-flop switch. Sleep and wake are constantly fighting to turn the other off. 3. NREM is the housekeeper, REM is the therapist. They have different jobs. 4. Messing with the body's clock is a super fire way to destabilize mood. And 5. Maybe the most important one for us. Treating sleep is not just managing a symptom. It's often a direct, powerful way to treat the underlying illness itself. And that brings us right back to where we started. We began with that puzzle, why sleep loss affects mania and depression so differently. We've walked through the circuits, the switches, and the different worlds of sleep that drive it all. So I'll leave you with this question to chew on during your next rotation. Given how deeply sleep is woven into the very fabric of mental health, is stabilizing sleep not just another tool in our toolbox, but maybe the essential first step to stabilizing the mind?